So my name is Gaurav Goyal. Some of you I know, and some of you I don't yet, and I hope to know you better as the day goes by. I'm an assistant professor in the Division of Hematology Oncology at UAB, and also affiliated with the O'Neill Cancer Center, where we are right now. So welcome here on this rainy day. Thanks for coming in, and welcome to everyone who are on Zoom. These are my conflicts of interest. So our objectives today will be to describe the signs and symptoms of Erdheim-Chester disease. It will be a good idea to be able to understand all the testing modalities involved when you diagnose someone with Erdheim-Chester disease. And also, hopefully, by the end of the talk, we'll be able to understand all the treatments that are available. I will cover a little bit about the future as we think, as I know where things are headed or where we are trying to make some progress and improve our understanding and treatments further. So Erdheim-Chester disease falls under this big umbrella called as histiocytic disorders. Now I say big, it is still, the whole umbrella is also a rare disease, but which makes things a little more complicated because you have a rare group of diseases and you have multiple subtypes of diseases in them. So histiocytic disorders by themselves are rare. They are actually derived from immune cells. Previously, it was not sure where they are originating from. People thought it is just originating from the cells of the organ they are in. But now we are learning for more and more of these disorders that they're coming from the blood cells. And it could be various types of immune cells, monocytes, macrophages. In some cases, they can be originating from the bone marrow as well. There are close to 40 or 50 types of histiocytosis. Some are, just varying presentations. Some can be overlapping with each other as well. And because of that, you have this large group of disorders. They can all range from just mild disease with one spot to disseminated disease or widespread disease affecting multiple organs. The Histiocyte Society in 2016 came up with the classification of histiocytic disorders and divided them into 5 groups. The L group is where Erdheim-Chester disease falls. It is the same group where Langerhans cell histiocytosis falls as well as a combination of these disorders. The other group is the cutaneous group that involves skin only, including xanthogranuloma. The R group, which is the Rosai-Dorfman disease group, which includes classical Rosai-Dorfman disease or Rosai-Dorfman disease associated with immune-related disorders or familial, which is seen more in children. The M group is the more aggressive types, the sarcomas, histiocytic sarcoma, Langerhans cell sarcoma, and the H group is hemophagocytic lymphohistiocytosis. It's a mouthful. It's an HLH that can be seen in combination with certain blood cancers in adults, as well as children in a familial form. The 3 I have highlighted in red are the ones that are more commonly seen in adults, sort of in the chronic histiocytosis group. And we are now realizing that Rosai-Dorfman disease may also have some similarities with LCH and ECD. So I'll be using these acronyms as we go by so that I don't have to say the whole word again and again. So LCH, ECD, and RDD will be the terms we'll be using. The first description of Erdheim-Chester disease was in 1930 by Dr. William Chester when he was visiting. He was from New York and he noticed these changes in the bones, in the long bones, and that's when the disease was described as Erdheim-Chester disease. So Jakob Erdheim was the pathologist where he was visiting, and that's when the first description was made. So as you look towards the events that have occurred since the first description, you'll notice that a lot of things did not happen up until a decade ago or so in the understanding of the disease. So the first description was in 1930, as I had highlighted. We did not know a lot till 2008 since that time. There were case reports. Interferon was being used quite a bit as it was being used in other blood disorders. And in 2008, Kathy Brewer, who is here, she founded the ECD Global Alliance to really work toward getting all the minds who are working on histiocytosis together toward a cure of the disease or toward finding better treatments for the disease. So that happened in 2008. In 2012, the BRAF V600E, the BRAF mutation, as you may hear it, that was discovered for the first time by Julien Haroche from France. And then in 2013, there was the first ECD medical symposium was held in San Diego. And that's when all of the folks gathered together and strategized on how we can improve our understanding of the disease. The first guidelines for ECD were published right out of the work that was put together in that meeting in 2013. And that's when we reviewed the group reviewed all the data and saw what is known and what is unknown. In 2016, other mutations, you'll hear this word often, MAPK pathway mutation. I'll discuss what that means. The MAPK pathway mutations beyond BRAF were also discovered. So now we were realizing that most cases of ECD are driven by some changes in the DNA of the tumor cell that gets it to multiply. The cells multiply and cause inflammation and organ damage. And then a study was done by Dr. Eli Diamond, trial for the first time in ECD in 2017 that led to the first drug approval by the FDA for Erdheim-Chester disease, vemurafenib, for BRAF mutated Erdheim-Chester disease. So as you can see, from 1930 to 2017 for the first drug approval. So it did take a long time for us to first acknowledge this disease as a cancer and then to do studies similar to that based on the mutations. And then more recently, we were searching for treatments for people who do not have the BRAF mutation. And cobimetinib, the MEK inhibitor, was studied, and it was shown to be highly efficacious in the patients who don't have these mutations. And now it's being reviewed by the FDA for potentially approval in histiocytosis, which don't have that mutation. And in 2020, we were able to, because of all these advances, we quickly realized from 2014 to 2019, we realized that there was a whole new world of knowledge and wealth of knowledge that has been uncovered about this disease. So we met and came up with the new ECD guidelines, which incorporates all these new mutational data as well as the newer treatments. So another question I get asked is ECD a cancer? So the answer is yes. Now that word does raise panic or anxiety in a lot of people's mind when it says, but it's also empowering in the sense that it opens a lot of doors for research and treatments. When we say a blood cancer, most people usually think of leukemias or something aggressive that will be lethal imminently. But ECD is considered more as a slower growing blood cancer, as some of you may be aware that it can take sometimes decades for it to get diagnosed from the first symptom onset, and can take a long time. It's slowly growing tumor. So in 2016, because of the discovery of the BRAF and other MAPK mutations, ECD was recognized by the World Health Organization as a histiocytic neoplasm. So the list here shows all the other histiocytosis that are officially recognized as cancer by the World Health Organization, and ECD was the one that was added in 2016. So that was a major advance in the field. MAPK pathway mutations. I do get that question often, what is MAPK pathway? So anytime we say a pathway, it is in the context of cancer. A pathway consists of several genes in the DNA, and the goal of the genes or the proteins, the genes lead to protein formation. Their goal is to carry the signal from the outside of the cell to the inside and to stimulate the cell to grow and survive. Now in ECD, you can have mutation. Mutation means a change in the DNA of one of these genes that can lead to an abnormal protein that can further lead to uncontrolled growth of these cells. So that's really what it means by MAPK pathway and a mutation in these pathways. So you can have all these mutations that are listed here, and that is how we came up with the targeted therapies. You find the mutation and you try to target them. Now ECD interestingly, is something that relies very heavily on a single gene mutation. It could be in the BRAF or it could be in the RAS, but it usually relies on one gene mutation as compared to some other cancers where you have multiple mutations where it becomes very hard to target it. The pie chart on the left shows the frequency of mutations in ECD as we know it today. So BRAF V600E mutation is seen in 50% or so of the cases. But other mutations that have been described are MAPK1, KRAS, NRAS, PIK3CA, ARAF. Now we are learning about CSF1R mutations, NTRK fusions, even beyond just the classic MAPK pathway mutations. That has opened doors for other targeted therapies beyond just BRAF and MEK inhibitors. So this is very important because it offers treatments for patients who may not respond to the targeted therapies that we think of as BRAF and MEK inhibitors. So this is a chart put together out of 80 patients when I was in fellowship. One of the things that is my interest is to help diagnose the disease in a timely fashion, in early, because I was seeing cases who had symptoms and findings for decades sometimes, and they would have diabetes insipidus or bony lesions, and the diagnosis was delayed by several years. And the first step in that was, is there any particular classic symptom or presentation with what Erdheim-Chester disease patients present with that we can say, hey, if this is the symptom, you got to think about ECD. So this chart was put together by Dr. Go, who was my mentor at Mayo Clinic, and basically highlights that the most common symptom was long bone pain. It's seen in almost 40 to 50% of cases, but again, it's a very non-specific symptom, right? Bone pain can occur in many, many conditions. Another unique thing I would argue, which is for ECD and LCH, is the presence of diabetes insipidus, where your pituitary function is affected by the disease, and you're basically manifests as drinking a lot of water, going to the bathroom a lot. You just want to keep drinking water with that, and that's a unique finding with LCH and ECD. Other manifestations are difficulty in walking. It's called ataxia because of its affecting the brain, the part of the brain that affects coordination and gait. Others non-specific symptoms are fluids around the lung or the heart, pleural or pericardial effusions, abdominal pain, changes in the vision, and 8 to 10% of the cases had no symptoms when they were diagnosed. So it's really a smattering of various manifestations. And the reason that is because ECD can affect so many organs. So it really depends on what organs are being affected to what degree, that will define what the symptoms or manifestations are. And also how long has that involvement been present, because the longer it is present, the more symptoms you will have. This is a chart that we put together from our Histiocytosis Working Group to capture in one image everything that ECD can do, or as much as possible in one image that ECD can do. So I'll walk you through this chart. And this chart basically highlights that ECD can affect any organ from head to toes. That's the unique thing about ECD as compared with other histiocytic disorders, and usually involves more than one organ system. So the most common finding with ECD that is now classic for diagnosis of ECD is the involvement of the knee bones. And it's almost always symmetric, involving both the knees, can be seen sometimes on an X-ray, but more commonly on MRI, PET scan, or a bone scan. And this is how it appears like. And if I see this on a scan nowadays, my brain immediately goes to ECD, and it is sometimes diagnostic. You may not have a classic biopsy finding, but you can have these findings, and with clinical manifestations, you can make the diagnosis of ECD. The other common features are involvement of the endocrine system, the hormones, where it can affect pituitary function and other hormones as well. It can involve the brain quite frequently, mostly the posterior or the backside cerebellum is what we call it, that is involved with the coordination, walking, and so forth. Another interesting or classic feature of ECD is these fatty deposits around the eyes called xanthelasmas. And these percentages basically highlight what we found in the literature and in our own cohort. It can involve the eyes, behind the eyes, and can put pressure on the eyeball. Can involve areas around the lungs. Another classic feature of ECD is this hairy kidney, where it involves the abdomen, and you can see this wispy sort of infiltration around the kidneys. That's called hairy kidney. Another finding is a tumor in the right side of the heart called, or that's very classic. It's captured mostly on an MRI of the heart, or coating of the aorta, the large blood vessel that comes out of the heart. And very rarely in males, it can involve the testicles, where we have found it to coexist with Rosai-Dorfman disease in the same case. So as you can see, multiple organs can be involved, and that's why it is hard for someone who is, so this patient can be seeing, for example, dermatology, maybe seeing neurology, maybe seeing cardiology or kidney specialist. And imagine them having to know that, hey, this could be Erdheim-Chester disease. Please think about that. That light bulb should go off. This could be on your differential. So it becomes very difficult to diagnose because of the rarity of the condition. It's not on the radar of most physicians when they see these cases. So it's important to spread awareness about these. I want to put a plug again about the hormone abnormalities, because they are sort of the invisible involvement, because your MRI of the brain or organ imaging may be fine, may be normal, but you can have a lot of hormones that are, lot of hormone function affected. So you can, mostly we see diabetes insipidus initially. That can occur even decade or 2 decades before ECD diagnosis happens or the bone findings come up. But you can have other pituitary dysfunction, growth hormone deficiency, prolactin deficiency, increase, and then you can have testosterone, estrogen deficiency, low thyroid, as well as adrenal gland insufficiency. It is important to know these because you may not be able to reverse hormone dysfunction by treating ECD. Even though ECD is responding on your MRIs or PET scans, you may not be able to reverse these organ dysfunction, these endocrine abnormalities. And it is important to continue to see an endocrine specialist in parallel. We have also seen that some of these may develop later after ECD diagnosis. So, and these hormone deficiencies can affect you in a multifold fashion. You can have fatigue, you can have, you're not able to, you're just not feeling good enough, you're weak, it can affect your mood. So it's very important to get tested for these routinely when you have ECD. Another area that my particular interest is in understanding the disease is this invisible involvement that affects the mind and the body in ways beyond what has been known historically for histiocytosis. And it can affect the memory, where you can have frank dementia in some cases. You can have difficulty with cognition, day-to-day tasks, memory issues. Very high prevalence in small studies now have shown very high prevalence of mood issues, depression, anxiety, just frank mood swings, personality changes. Chronic pain is another issue that's emerging. And these are despite patients being on treatment and responding. So we really don't understand why this happens for sure, and what to do until we, it's hard to tell what to do until we know why these are happening. But the chronic fatigue is another reason. And it is very important for clinicians to acknowledge these symptoms, for patients to acknowledge these symptoms and to mention that to their caregivers, to their doctors, because that's, I think, the first step is to acknowledge them. And then you can engage other specialties, supportive care clinics, pain specialists, psychology. A lot of times you need medications for anxiety and depression. And I have seen that help the overall well-being, because if you're feeling better, you will want to be more engaged in your care for ECD in general. So this is a topic that's very close to my heart, and I'm working on exploring these questions more. Another thing we have realized is that ECD is not as distinct or separate entity altogether as we thought it would be. And we have seen it overlap or coexist with Rosai-Dorfman disease, where it is driven by the MAPK1 mutation mostly, and coexist with Langerhans cell histiocytosis, where it is driven by BRAF mutation mostly. So now we are at a point where we see a case, we have described the clinical features of these enough that we can say, hey, you may have LCH and ECD at the same time. It's very important to know that, because that encourages the doctors to pursue additional biopsies to make the diagnosis of both the entities, or to pursue additional testing. And that is why it is very important to know the symptoms or the manifestation for LCH and RDD. Even though you have ECD, it is important to know that, because that empowers you to recognize that, hey, this could be LCH. So now LCH is a little different. It involves bones quite commonly, but the lesions of LCH, lesion is a term that you'll hear often. Lesion is a spot that the cancer affects. That's called a lesion. And it's very different than ECD. As you can see in this image, you see this sort of burrowed, punched out, scooped out lesions. And it mostly involves the central part of your body: skull, jaw, the spine, ribs, pelvis. Not as much as the long bones of the legs and so forth. So that's a unique finding. Another common feature with LCH that is almost always seen in smokers is the lung involvement, where the upper part of the lung has these tiny cyst-like structures, can be seen on CT scan or here in PET scan. That is called pulmonary LCH, and a lot of times it goes away after quitting smoking entirely, and that's still the #1 treatment for that entity, but a lot of times it does not. It tends to involve the brain less commonly, can involve the covering of the brain. It can cause diabetes insipidus at a similar rate as ECD, and other hormone abnormalities can occur as well. Very rarely can involve lymph nodes. ECD or LCH don't tend to involve lymph nodes that commonly, but skin involvement is another common finding, presents in the form of a rash. So it's important to know just these features. If they occur, you got to think about coexisting LCH. Similarly, Rosai-Dorfman disease is a unique entity in that it is it's much commonly seen in females. It also can affect any organ of the body, but more commonly involves the skin and sort of forms lumps under the skin, nodules under the skin. It can involve lymph nodes much more commonly than ECD or LCH can. It can involve any bones of the body from head to toe in terms of small lesions. It can involve the eyes rarely, or the covering of the brain, or the airway that we breathe. Not in as much the lungs itself, but more the airway. So that's again a unique distinction. So it is different than ECD in that it doesn't, again, rarely involves the brain, rarely involves the long bones around the knees, but there are some similarities. In patients with ECD and RDD, we have seen them to be mostly men who have testicular involvement. So that's something to keep in mind. So how to diagnose ECD in 2022? We have realized that ECD is different than other cancers, even than other histiocytosis, in that you can't simply just do the biopsy, look at it under the microscope and say, oh, this is ECD, which makes it hard to diagnose. This is an entity where the clinician who is seeing the patient has to talk to the pathologist and the radiologist, look at everything together, and then come up with a diagnosis. So the pathologist needs to know the clinical features to make the diagnosis. So that's why the term is clinical pathologic diagnosis. So you may have one of these features. The long knee bone involvement is the most common feature, can be seen in over 90% of the cases. So that's a classic telltale. But you can have these xanthelasmas around the eyes, you can have the hairy kidneys, tumor in the right side of the heart, coating of the blood vessels around the heart, and including the involvement of the pituitary gland or the brain part that controls your balance, the cerebellum. And the biopsy showing some features of inflammation, fatty cells, we call it. We do staining on that. Staining is when the pathologist throws certain dyes and then looks at it under the microscope. And if it comes back positive, then it says positive staining. So there are certain markers. So as you can see, CD68, factor 13A, and this case particular was BRAF positive, so the BRAF stain would show positivity. And now we are layering another component to it, which is the MAPK pathway mutations. So you could have a case where you could have the long knee bone involvement, and you may not have these findings because there are not enough cells in the biopsy, but you can find a mutation maybe, and that's diagnostic. In some cases, you may not have either of these two, but you have these knee involvement and maybe one other feature, then you can think about ECD. You could have the biopsy features with the mutation without any of these classic features, and then you can make a diagnosis as well, which is sort of the non-classic form of ECD, which doesn't involve the long bones. So this is another part of ECD that is very unique, and it is important to know that it is not just simply a biopsy-based diagnosis. Did that make sense? Okay. And we'll have time for questions afterward. Now, once you diagnose ECD or you suspect ECD, actually, what evaluations are needed? Because sometimes you may have a case where you may not have the diagnosis, but you're suspecting it. So what do you do then? So this is from the latest ECD guidelines. The number one thing that we are recommending is to do PET CT, including toes. Traditional PET scan goes to the mid-thigh, but for histiocytosis, it is recommended to go from skull to the toes, top of the skull to the toes. It is important because otherwise in a traditional PET scan, you will miss the findings around the knees. And I have seen cases where that occurs, where the PET scan doesn't capture those features. The other thing to do once the diagnosis is made is to do an MRI of the brain, because you have seen involvement of brain even without symptoms, so to catch it early. And the third thing that we try to do is cardiac MRI, MRI of the heart. Echocardiogram is not sensitive enough to pick all the heart involvement. So it is important to do that if possible. Now we realize there's a lot of imaging and testing in the beginning, but it is this package sort of is similar to what we call staging in other cancers to know your ECD in detail. The other thing that is now recommended is to look for the BRAF mutation. And in some cases, you have to really search for it. We know that people who have BRAF mutation have more likely heart involvement, brain involvement, and the knee bone involvement. So those cases, we really search for it. And sometimes the biopsy testing may not be conclusive, so we may have to do blood-based testing. The other mutations can be tested using, there are commercially available panels. A lot of your institutions where you are, they may have in-house panels, but the key is for them to have a group of genes, not just select one or two genes, to look for any rare mutations that could occur in these disorders. And then also look at the RNA expression for certain gene-gene fusions that we are discovering, where two genes can come together and drive the disease, and that can be targeted. But as you can see, otherwise, you have to do a comprehensive history, including all the symptoms, do a comprehensive physical exam to look at all the manifestations. A lot of times when I see patients, I refer them to members of our histiocytosis group here for especially neurology, endocrinology. They need additional evaluation. And then if they're starting targeted therapy, they may need to see dermatology, they may need to see cardiology, they may need other testing based on what treatment they are starting. Other lab tests that are necessary include a complete panel of hormones, including the pituitary function, as well as other imaging studies depending on what organs are involved. Sometimes if there is spine involvement, you want to make sure it's not involving the nerves, so MRI may be needed on top. But the two areas that I've highlighted are sort of the new things, and it can be sometimes hard to get insurances to cover for a full body PET scan, so we have tried to incorporate that into the guidelines. And the new NCCN guidelines that came out for histiocytic neoplasms also recommend doing a full body PET CT scan. So hopefully that becomes easier now. Treatment options for ECD have evolved a lot in the last decade, I would say. So we tend to divide them into two groups: the conventional treatments that were being used before targeted therapies, and now targeted therapies. So targeted therapies include BRAF and MEK inhibitors. And actually, I updated this slide for this talk because now we are seeing signal that there are other targeted therapies in single cases that have been used where you don't have those mutations that can be targeted by BRAF and MEK inhibitor. But it's still very early to discuss in details about those. Conventional agents include interferon, which was always being used, and it could be pegylated interferon or general chemotherapies. Cladribine, cytarabine, methotrexate, vinblastine has been used in the past. Anti-cytokine, rheumatologists use this drug, anakinra, and so forth, tocilizumab, infliximab, and some other treatment modalities that were used. Now, steroids, radiation have very limited role unless there is urgent need to decompress or sort of reduce the tumor bulk. They don't really help as much in ECD actually. So it's not usually recommended to use those drugs. And here are the trade names of some of the common targeted therapies that we use. So if I say vemurafenib, it could be, it's alluding to Zelboraf. So not to confuse you, some clinicians like to not use the trade names, they use the generic names. But these are the names of the drugs here. So how do we treat ECD? So this is our treatment approach. I would say most ECD patients, by the time they're diagnosed, they do require treatment. Now there are very select few instances where you have just maybe bone involvement or maybe a little bit of hairy kidney without any problems, and you can watch them. Now I say that very carefully because the accurate term for that would be surveillance, where you cannot just say, well, you'll be fine, but you have to follow up on that patient to make sure that those lesions are not progressing. So, but eventually those patients will require treatment. If possible, if close to you, if there is availability close to you, enroll in a clinical trial. It's hard to come by those clinical trials, but talk to your oncologist about those. But pretty much, as you can see, the red boxes, the treatment for ECD is really defined by what your mutation status is now. So if the patient has, if you have BRAF V600E mutation, and if you have severe symptoms, we recommend doing a BRAF inhibitor. If you have mild to moderate symptoms, no critical organ involvement like brain or heart, you could consider one of the conventional agents that I showed in the other slide. And cladribine and interferon are reasonable alternatives. Anakinra is a reasonable alternative, but in our practice, I would still favor use of BRAF inhibitor, knowing that the disease is driven by the BRAF mutation. People who do not have BRAF V600E mutations, a MEK inhibitor like Cotellic can be used, or a conventional agent can be used. Now the response rates, bear in mind, are higher if you have a BRAF mutation and you get on the Zelboraf or the vemurafenib. It's pretty much guaranteed that it will work. It is not the same for conventional agents. If you have a BRAF mutation, it may not work in every case. Similarly, if you have the MAPK1 or a KRAS mutation MEK inhibitor, there is a high chance it will work. Conventional agent, we don't know for what patients conventional agents work better. You can have rare cases of these fusions that I was talking about, where two genes come together to activate the MAPK pathway. And those fusions actually have inhibitors available. They are off-label. All these drugs except vemurafenib are off-label. I just want to mention that. So your doctor's office will have to appeal and get that drug off-label approved for your disease. And if they're not available, you can still try a MEK inhibitor or a conventional agent. Now, if somebody is acutely sick, if they have a lot of symptoms, these genetic testing can take a couple of weeks or even longer, depending on where the tissue is. The lab has to get the tissue, do the testing. The results take a while to come back. If someone is very sick and we don't have time to wait for those tests, at the very least, they could do a BRAF stain that can be done in most large centers locally, or a rapid BRAF testing. And if that's negative, we could consider a MEK inhibitor empirically, which we have done, which is just a matter of odds. We think that MEK inhibitor will work regardless. In patients who have the BRAF mutation, the MEK inhibitor should work even in those cases. So just using it while you're waiting for additional testing is not an unreasonable approach to use. But you can always use a conventional agent. Now these things are driven by whether you get the drug, whether you tolerate the drug, of course. So it's more a guidance rather than just saying, well, this is the only way to do it. Does that make sense? Okay. Once you start treatment, it is very important to monitor things closely. You cannot just say, well, you're good, you don't need to see me again. The most important thing is to do, if you're doing PET scan, which is recommended, do a PET scan in a few months after that to see if the brightness of those lesions have reduced. I try to do it initially 2 to 3 months after initial starting of therapy. If I'm seeing a response, I do it again in a few months after that. But after the first couple of PET scans, when you have seen that, oh, it's responding, it's getting better, you can have a partial response, or you can have a complete response where the entire disease entity, the brightness goes away. After that, you can discuss with your doctor, you can space it out even further, because initially it's important to know whether the drug is working or not. It's also important to do other imaging studies if they were abnormal in the beginning. If the brain MRI showed brain involvement, you want to repeat the brain MRI. Endocrine evaluation, I'm going to say that again. It's very important to continue to see an endocrinologist if you have endocrine abnormalities, or if you develop new symptoms concerning for endocrine abnormalities. As, for example, if you are on DDAVP, the desmopressin, you will likely stay on that desmopressin even after starting treatment. There are rare instances where you may be able to go off of that, but that has to be done in conjunction with your endocrinologist. Another thing that we are recognizing more and more is the other symptoms, the invisible symptoms, the pain, the fatigue, and the mood issues. So it's very important to see supportive care or palliative care in some clinics, some cancer centers they call it, and to manage those symptoms, because they are really specialists in those. And sometimes it's easy to get focused on just the ECD treatment, the targeted therapy, and forget about the later part. And it's important to manage those in parallel. And then, depending on what complications you're expecting, what testing, what drugs you're on, if you're having side effects, you may need additional evaluation. But you pretty much need to be followed up by your clinician for life, I would say, right now, based on what we know about the disease. So given how many organs can be involved, it is very important to have multidisciplinary care for ECD or other histiocytosis. So after coming here at UAB, I was able to establish a histiocytosis working group members within UAB from these subspecialties. When I was at Mayo Clinic, that's where we started. So it's a large working group with a tumor board where we discuss cases once a month from both institutions. And you can get evaluation benefits even without seeing some of the doctors in that format. And I think this is very critical for a disease like ECD that involves multiple doctors. The other benefit of having this collaboration is that sometimes these doctors bring cases that, oh, hey, this looks like ECD, this may be from their clinic. So that's another. So there are multiple benefits for having a team-based approach. So it is highly recommended to have at least one evaluation from a multidisciplinary center or a center of expertise. As an ECD Global Alliance has a list of those centers on their website. I'm going to talk a little bit about unanswered questions. It's not supposed to provoke anxiety, but I think it's important to know what we don't know. And one question, which the next slide I'm sure a lot of you will have, is can we stop the targeted therapy now? I'm on this BRAF inhibitor for a year now. When do I get off of it? Now I'm doing fine, I'm getting better. Can I just stop it? We don't know the answer to that. What we know from a small French study, and actually there's another study that was presented, was that it was a 20-patient study that showed that if the BRAF inhibitor was stopped, the disease came back in 75% of those cases. So as of now, the approach I use is you stay on the BRAF inhibitor for as long as you can tolerate it. Now, I view this more as a chronic disease where you may have to play with the dose. You could lower the dose as long as the patient is responding. You can have side effects, so that may require drug holiday, a break from drug. My great partner here, Ginny Tyler, she's going to talk about the side effects of the drugs, because that can drive stopping the drug here as your treatment goes by. But the point of this is that you have to do this in conjunction with your oncologist or your hematologist. So I would recommend not just sort of stopping it on your own, like, if you're not feeling good, because there are things that can be done to manage those side effects sometimes to keep you on the drug. So right now, we don't know. Well, could there be select cases where I would say, well, you've been on the drug for for 2 years now, you're in complete remission, let's give you a couple of months break. Perhaps there may be some cases I could do that. But right now, if you're getting a response, I would stay on the drug. And we are exploring other approaches, whether we can sort of do BRAF inhibitors for 2 years and then give chemo at the end for a couple of months to kill any of the little cells that are remaining. Because the thought is that the BRAF inhibitors or the targeted therapies are good at suppressing the growth, shrinking the tumors, but it doesn't kill all the cells. So maybe a chemo at the end may help. We don't know the answer to that right now. And it has to be studied in a clinical trial format or in very close discussion with your oncologist. So that's not recommended right now. The other question that is my main interest, other than the curing of ECD, is now we are, with the improvement in therapies, we are seeing a growing survivor population, which is a good thing. Survivor means your ECD is under control, and you're hopefully your ECD is not going to lead to mortality in those cases. So the prognosis of ECD from ECD itself has improved. And that has led to, fortunately, which is a good thing, a growing survivor population over the last few years. But these patients are also on prolonged treatments. They have been on many treatments, or they are on these targeted therapies for a long time now. And they are likely to stay on those treatments for a long time. In addition, ECD involves many organs of the body. So what we don't know is what happens in the long run in ECD, right? Do patients who get ECD and get treated, who are in remission, do they get to live as long and as happy, healthy life as somebody who never had ECD, their age? We don't know the answer to that. And that's been done in other cancers that are treated, like lymphomas. That's been done in many other cancers, but not in histiocytosis. So what we know in other cancers is if you have this growing survivor population who is on these treatments, you can have mortality or reduce life expectancy at the later point from chronic health conditions, especially in a disease which involves multiple organs or you're on treatments for a long time. And those can lead to mortality later on, like heart disease and lung disease, infections, and so forth. We don't know that in histiocytosis, if that's the case. That can also lead to increased healthcare needs, healthcare utilization, going to doctors for other things, and so forth. And eventually, there is a term that's used called quality of life. Because the ultimate goal of medicine or oncology is to make the patients live longer and to make them live healthier and happier lives. So that's piece of the quality of life, and how the chronic health conditions can lower the quality of life. You can have pain from the disease itself. The inflammatory findings can cause chronic pain, and you can have depression, anxiety, and that can affect your quality of life as well. So there are many other facets to this, and so that needs to be studied. I think that's the need of the hour, because right now I'm not able to tell a patient what to expect in the future or 5 years down the road, which is important to know. So to answer that, we launched this Histiocytic Disorder Follow-up Study here at UAB. We are partnering with the Histiocytosis Association and the ECD Global Alliance. And the goal here is to really see what happens to ECD patients once they are diagnosed with ECD. What's going on in their life? Are they able to function? Are they having chronic health problems? How often are they seeing their other doctors? What is their psychological health status like? What is their quality of life like? And in that, then identify what particular group of patients are at higher risk of those problems. And this will likely lead to development of guidelines for long-term follow-up of these patients. So really what would be needed, if you're interested, is to just fill a survey, a questionnaire that you can fill up. It's a form, and you can just you can call this number or email us, and you'll get a nominal gift card for that as well for your time. But this would really be helpful in defining in a large study what are the outcomes of ECD patients. We'll also be able to define the mortality and what are the causes of death. If you are really interested and have energy and time here, I actually did bring some packets here for the study that my study team put together. And you don't have to fill it here. You can take it with you at home. But the envelopes here you can mail it back to us. But for those on Zoom, you can email us or call us to get on this study if you're interested. So what are the takeaway suggestions? I would say that empower yourself with the knowledge of your ECD. That's the number one takeaway lesson. Don't just be a passive sort of spectator. I would say just empower yourself with the knowledge of your ECD. That's very important. And because I learn a lot from my patients. When my patients tell me, hey, this symptom, this new symptom is coming up, if I pay attention, sometimes you uncover other complications and things. You should know what organs are involved in your body, know what mutations are driving, what are seen in those genetic testing that has been done on your tissue. You should have all undergone genetic testing. I mean, sometimes it's not successful, but at least an attempt should have been made. When new symptoms come up, new findings come up, it's okay to re-examine what's been given, what are we doing, what are the other treatment options that can be done. I cannot say this enough, treat depression and anxiety, and because we put too much weight on those pills to fix everything in our life, but they unfortunately don't. We are seeing that. You can have other symptoms. So please manage those symptoms as possible. A lot of times you need medications for those as well. And no matter wherever you are, please think about getting a second opinion at a center of expertise that is maintained by ECD Global Alliance. Now we have telemedicine, at least getting one consult with a multidisciplinary group is not a bad idea. So you learn new things. Most of us are very collaborative with each other. We work with your local oncologists, hematologists regularly to manage care. And then get involved in research as much as possible, because a lot of what I shared today is known because someone before you who was diagnosed with ECD agreed to involve in research. So at UAB, we have the survivor study. We have a biobank. Most of the large centers you'll go to will have a biobank where you will be asked to donate a little bit of your blood or maybe the biopsy sample for future research. The ECD Global Alliance has a registry. If you are enrolled in that, that really opens doors for any future studies that happen. You'll get alerts for that. So it's very important to be involved in research. And I would say be your own advocates, and you can do more than you think you are able to. Kathy Brewer is a classic example, how she galvanized all of the resources and, which led to all these things that I discussed with the discoveries. So I would say, educate your community, your doctors, people near you. I think you can make a huge difference there. Studies that we are doing, we have the Histiocytosis Working Group now that's been expanded to UAB, Mayo and UAB. We meet actually twice a month. It's really, fortunately, it's expanded so much that we have a separate research meeting and a tumor board where we discuss cases as well as research projects. We were able to launch the NCCN guidelines, which we are members of, and those guidelines are for which are standardizing the care in community and everywhere. Oncologists look for those guidelines for managing for histiocytic neoplasms. We are also doing testing on DNA and RNA to uncover other causes that would be driving this disease, doing blood-based testing, identifying new targets for therapy. My interest specifically is in undiagnosed histiocytosis, capturing those cases that are being missed, because it's really, really important that we capture all the cases, because at some point we cannot just keep saying, oh, it's very rare, we don't see these cases. I think they are there, it's just not being diagnosed in a timely fashion a lot of times. Trying to explore options to cure ECD, maybe sequential targeted therapy followed by some sort of chemotherapy. Looking at late effects of treatment and the disease, the survivorship aspect in the follow-up study that I discussed today. And we have an ongoing registry and collaboration with biorepository, where if you see me, you'll be asked to, you'll be offered to be part of that, to store your blood and clinical information for research. That's all I have. I cannot do any of this, couldn't have done any of this, or none of this would have been possible without the support of patients and families. These are my mentors, DOB, Mayo Clinic, and MSK. I'm very thankful to Histiocytosis Working Group. I also do similar work in HIV-associated malignancies, the survivorship work. So I'm thankful to the team there. This is my research team at UAB who is helping with a lot of these studies. And these are my funders and supporters. I'm very thankful to the ECD Global Alliance for giving this opportunity. This is the most joyful part of my work, to be with the patients and to spend time with them, more so than I just get from just writing papers and doing research. So thank you for your attention.